We'd like to invite all our speakers, please, both patient and medical community, to the front for our second panel discussion. So if I could have Dr. Tashima, Dr. Swallow, Laura, Kelly, also genetic counselor Melissa Aronson, who works at the Zane Cohen Center. As well, we have a caregiver speaker, Ramandeep Singh, if he could also join the discussion. Now, my understanding is we have a lot of questions online, so I'd like to just give an opportunity to the people online to ask the questions first.
Thank you. So now that we have geneticists on the panel this time around, I do kind of want to repeat the question. I know, Laura, you discussed it in your Q&A as well, but there was a question online just asking, when you do genetic testing, what percentage do the hereditary genes express themselves, and is it advisable to do genetic testing for siblings and children?
So the international community has put out criteria on who we should be testing, and if you meet the criteria, which would be if you're diagnosed with diffuse gastric cancer under age 40, or you have 2 cases of diffuse gastric cancer in your family, or family history of diffuse gastric cancer and lobular breast cancer, those are the families that they generally suggest to test. And when you test them, you'll find a CDH1 mutation in about 10 to 20% of them. So that means 80% of families that we highly suspect something's going on, we can't find mutations in CDH1. There is now a panel of genes aside from CDH1, including Lynch syndrome, which I heard mentioned, and the BRCA genes and other genes that we put on. And that bumps our numbers up a little bit. So if you do have a family history or you're diagnosed at a young age, we test anybody under 50 with diffuse gastric cancer. And if you have intestinal type gastric cancer and a family history of especially colorectal or pancreas cancer or freckling inside your mouth, there's a few different syndromes we think about, then you should be referred to genetics and be tested.
Then following up to that, are all gastric cancers genetically tested, and are all gastric cancers genetic?
So most gastric cancer is not hereditary. All cancer is genetic because all cancer is something going wrong in the cell in the genetic makeup of it. But most cancer is not hereditary across the board. And in gastric cancer, probably 80% is not hereditary. The other 10% or so, well, 20%, but 10% we can't find mutations. But in the other 10%, whether it's diffuse gastric or intestinal type gastric or GIST or other types of gastric, it could be hereditary. So yes.
Okay. So another question we have online is there any progress in obtaining better imaging for Signet ring cell?
So I'll just talk about cross-sectional imaging, and essentially the answer is no. There's a lot of discussion about functional imaging, single cell identification, but at this time we don't have enough detailed imaging to track these individual cells. They're very, very sneaky, and as Laura said, they can get past a membrane barrier and actually spread without anybody suspecting that they're there, and that's why it's so dangerous and difficult to manage if it's too late.
And likewise with endoscopy, the detection ability of our cameras are not sufficient to localize the spot where the cancer cells are located. And so, we, in the right clinical scenario, maintain a very high index of suspicion. So we saw a patient last week who had been followed elsewhere for some months now with the abnormal thickened stomach, and had some vague upper GI symptoms that prompted endoscopy elsewhere, and they kept having biopsies elsewhere that are repetitively normal. And so our endoscopic imaging was no different. The stomach looked very thickened, but the surface looked normal. The surface pattern was normal, and I did endoscopic ultrasound, which basically allows us to look, Dr. Swallow showed an image, beneath the surface, but even then, things just looked diffusely thickened, but not localized. And so recognizing the possibility that this could be the diagnosis, we took basically large, not biopsies, but in a way where very small lesions, we can cut them out in chunks. It's almost like taking like a melon ball out of cantaloupe. And so we took like 15 to 16 different divots from all over the stomach and really deep samples. And within that, most of it was negative, but there were tiny foci, 2 or 3 tiny foci that showed signet ring. So unfortunately, again, this patient had seen, I think we were the 4th opinion. So it's a hard, we can't see it. So the answer, no, we can't. So unfortunately not, but we can try.
So then we just have a couple more questions. So it's just, when there is cancer outside of the stomach, peritoneal, is HIPEC an option, and can you pay for HIPEC privately?
So yes, HIPEC is an option because almost anything is an option. I think that there is no international consensus on what the benefit of HIPEC for gross peritoneal disease is. The situation in appendiceal cancer is probably the closest to being at a consensus level. Colorectal cancer, there were just recently results that came out suggesting that the heated intraperitoneal chemo doesn't actually improve anything beyond the cytoreductive surgery part, which was disappointing to many people who have advocated HIPEC over the years. And for gastric cancer, I think the answer is even further away. So the experience in places like France and the Netherlands, where they've used HIPEC for grossly apparent peritoneal cancer from gastric origin, has been pretty negative overall. There are a couple of ongoing studies of this in those 2 countries, but the results are not going to be out until the mid-2020, so 2025 approximately. We won't really have any good evidence as to that question. Having said all that, there are centers in Canada, and Calgary is one of them, where they consider patients with minimal peritoneal disease who are very fit, young, otherwise well. They consider them for HIPEC and gastrectomy. So it is being done in some places in Canada. In the US, for sure, there are lots of places where you could get that treatment. And if you have the money to afford it and you want to, you can buy yourself that treatment. Does anyone else have any comments on Natalie, do you want to say anything?
Yes, thanks. Yeah, I think Carol's correct. You can probably, I'm sure you could go to the US to buy that treatment. I think in many cases that would not be advisable, and we have much better chemotherapy drugs than we did in the past. And a lot of people look to surgery as the answer, and perhaps we should be looking to our medical oncology colleagues. So maybe I'll pass it to Christine on that then.
Wow, really
I get the last note here. Yeah, I agree. I think there's a very good systemic therapy, so the chemotherapy, the targeted therapy. You've heard through Stephanie's presentation pushing the envelope for immunotherapy. But as you mentioned, there may still be a role. We are now, the way that we treat patients with gastric cancer, probably in the bigger centers and bigger cities, is that we perform diagnostic laparoscopies on them at diagnosis to determine whether or not they are candidates for curative therapy, as opposed to a patient going directly to surgery. So we determine what is the extent of the disease, specifically patients with diffuse gastric cancer. We see, even though there's minimal disease on biopsy, in the peritoneum, it tends to be positive. And so we are now not treating them with a gastrectomy, but we're giving them chemotherapy. And these are patients actually who do live slightly longer because we're not removing the stomach. Their nutritional status is maintained. And this may be a population, Carol, we were talking about it earlier, whether or not patients that don't have a lot of burden of disease within the peritoneum, with the stomach still intact with gastric cancer, whether or not they would benefit from HIPEC. I think that's a question we still don't know. But for diffuse gross peritoneal disease, I think that is probably not going to be a curative approach.
I had one more question from one caregiver that recently their partner was diagnosed with stage 4 gastric cancer and essentially told that there's a role for palliative care. They had a lot of questions regarding palliative units, palliative beds, hospices, home death, and also about talking to children about cancer. So I think I'd like to just open the discussion regarding that and the caregiver role.
Hi, thank you. I could talk a bit about that. I could actually go on and talk a lot about it. But so I think it's a very personal decision to make. How and when you do tell the children. I'm just starting with that part because it's closer to me. I take care of 2 of my own children at home by myself. But being honest, I actually told them about their mom on Christmas Day 2 years back. After they'd opened their presents, of course. And that wasn't going to kind of deter them. But they do bring it up even now that they appreciate the fact that I was honest, straightforward, that they had mom at the time there to also talk to them about going through what it's going to mean and the changes. Children have much more tenacity than we give them credit. So I would always say, be honest to them up front. I've met a lot of patients, a lot of caregivers, a lot of parents who've said, no, we haven't told the kids anything. We want to, keep it till the end. That's time lost because you know what's coming and you want to get them prepared and you want to make sure that you spend quality time with them. Coming to the point of palliative care, I think we, as everybody else is, were very, very reluctant in the beginning. We were at Toronto General. The idea was, it was proposed to us that we could move to the palliative unit at PMH. I was the one who was up in arms against it because I felt it would totally take away the care that was being given to my wife. But I was wrong. I think the team did a great job. We moved to hospice after, the Stedman Clinic in Brantford. I think those are some of the best care that Megha got at the time. I think it's about quality of life. And I think that's the most important piece at that point. Of course, you are not doing anything curative, but if all of that has been dealt with at the point already by the physicians who are taking care of you and the surgeons, I think at that point it's a mental makeup to decide and move forward. So I have all good things to say about palliative care and hospice and the teams who spend a lot of time and give a lot of effort because it's not easy dealing with families and patients at the time. So a big shout to them for doing what they're doing and keep doing what they're doing because I'm sure emotionally it takes a lot from them as well. And I will definitely support patients and families wanting to opt for that. Thank you.
Thank you so much for sharing that.
May I add?
Absolutely.
Okay. Is this on? Yes. There has been a lot of research done on talking to kids about cancer and when the right timing is. And we recommend for people, as you stated, to tell the kids early on. Kids need to know in pieces, but there have been studies that have shown waiting until someone is dying, the level of anxiety is actually much increased rather than giving the kids open and honest communication that they absorb over time. And kids are smart, they know something's wrong. So by hiding a diagnosis or not sharing a diagnosis of cancer early on, as hard as that is, it can actually make the kids know that something's wrong. It can be anxiety provoking in itself.
Thank you. We'll take a couple more questions in the audience.
Sorry, I'm always asking questions. I was intrigued by the stat that more than half of cancer, when it's caught here, is in a later stage, and then in Japan, it's much earlier. I want to know why, but also I'm assuming I know the answer to this, that most of those cases are not diffused cancer, the ones in Japan.
Correct. So, we're having a different conversation here because many of the people in this room are affected by CDH1, and we're talking about diffuse gastric cancer and hereditary syndromes. In Japan, it's, in China, Korea, it's Helicobacter pylori and intestinal type adenocarcinoma. And they have had a screening program in Japan since the 1960s. And it was the leading cause of death. So it was something and remains something that's very, very on the forefront. And because it's so common, I think people are very well trained. So there's a societal understanding about the disease, which is lacking here, dramatically lacking here. And if you look at amongst my field, there's much more attention given to Barrett's esophagus, which causes much fewer cases of cancer than stomach cancer. So people are much more aware of it. There's a screening program which institutes it into the mindset of what's done. There's access to endoscopy, very easy access. There's actually a mobile endoscopy cart, like buses going around. You can get a scope there easily, probably within a week. It has to do with the way the healthcare system is funded as well. So screening, which becomes cost effective when there's high prevalence, when a lot of people have a disease, and societal understanding, and then different biology as well. So it's we're seeing intestinal type cancers. But this is changing also in Canada. Like there's so much Asian immigration that we see increasingly these same kind of cancers. And as we begin to talk about this, when I was a resident, which wasn't that long ago, but 2006, this was something that was, we just don't see this here in North America. And that was the answer. Well, this is different biology. You guys have these different diseases. We don't see these things. But now there's so much more interaction with different countries and doctors from Asia. And we have fellows who come to our hospital to train from Japan almost every year for certain things, but we've learned so much from them in the last 5 years that we've become much better, and now we're trying to teach our colleagues how to be better. And now that we know what we're looking for, we're finding these things increasingly.
Hi there, everyone. Just want to say thank you for all the knowledge you're sharing with us today. And I'm here on behalf of my sister, and I just want to say that we feel very blessed that her doctor is Dr. Swallow, and she's been great with her. I just have a question for Dr. Swallow. So when the cancer is spread in the peritoneal area, and so we don't know if it's reoccurrence, what are the options? Are there options?
Yeah, it's a really hard
And it's just growing.
question.
Yeah.
And obviously one of the keys is prevention. And that's something that in my lab, we're actually actively looking at. Is there a way to prevent peritoneal spread in people with high-risk cancer? Could we actually use HIPEC at the time of the resection of a high-risk cancer to wipe out those cells and prevent it from ever coming back in the peritoneum? But once it is in the peritoneum, a lot depends on how much tumor there is. So as I was showing, if it's just microscopic, prognosis is actually significantly better. And with chemotherapy, patients are not going to be cured in the vast majority of cases, but they can live for a longer time with better quality of life. And compared to when I was a resident, it's really really a revolution in the way we're thinking, because at that time we said, well, that's it. There's nothing to do. There's no IV chemo. There's no surgery. There's no HIPEC. There was no discussion. And now we're actually talking about how to try to prolong and improve the quality of life of patients with that stage of just cytology-positive peritoneal cancer. I guess in terms of gross peritoneal disease, I think that's one of the most difficult situations in terms of symptoms and symptom management. But there is chemotherapy, there is systemic therapy. And I don't know, Dr. Snow, do you want to say anything about managing symptoms in those patients with peritoneal disease, and are we getting anywhere?
You're quite right that some of the symptoms that go along with peritoneal disease, especially bulky peritoneal disease, can have a huge impact on quality of life. We've talked a lot about nutrition today and those upper GI symptoms, but if you have a lot of cramping, for instance, and those types of things as food moves through the lower GI tract, that can be quite difficult. And some patients will get a large volume of fluid in their abdomen as well, called ascites, related to that disease. And so in order for us to be able to give our systemic therapies, we have to have patients who have to have a certain amount of functioning, have to have a certain amount of nutrition, those types of things. So these are some of the cases where that early involvement of palliative care is very important, because they truly are the symptom management experts. They do many things, but they are another person to go to. Sometimes I find that using some steroids as the anti-inflammatories can help to get people through symptoms and to try to get those therapies in that can then lead to some debulking and making patients feel better.
So if there are no more questions for this panel, thank you so much. We are going to take a short break.